For just a few housekeeping items, our webinar is being recorded. It will be posted on our website, zerocancer.org, tomorrow. And as soon as the webinar closes, you'll see a link to a really important survey we would love for you to participate in so we can get your feedback on tonight's event. Tomorrow, you'll also receive an email with a link to the recording and the survey. For those of you not already familiar with Zero, the End of Prostate Cancer, we are the leading national nonprofit with the mission to end prostate cancer. Zero advances research, improves the lives of men and families, and inspires action. If you're new to the Zero community, we welcome you, and we are glad you have found us. At Zero, we have a lot of patient support programs and educational tools. These are all, of course, offered at no cost to our patients and families. So if you or someone you know is in need of resources at any time during your prostate cancer journey, please share these resources with them and let them know we are here to help. So I'd like to spend just a couple of moments highlighting a few of Zero's patient support programs. First, I want to talk about Zero 360. Zero 360 is Zero's comprehensive patient support program. It's a patient navigation service and provides individualized case management. These are trained case managers to help patients and their families connect with financial assistance opportunities, navigate insurance, find a lot of different supports, food pantries, help with transportation, and even emotional support. Zero also offers peer-to-peer support through our mentor and caregiver connector programs. This is a program in which we match patients and caregivers with someone who has been on a similar journey, and that person can help provide ongoing one-on-one support. We also have Zero Connect, and this is our online patient Facebook support group. This is a private group where you can connect with others affected by prostate cancer. You can learn from their experiences, ask questions, and get advice from patients and their loved ones all over the country. We also have a large educational suite full of informational sheets, our website content. We have questions to ask your doctor, patient toolkits. All of our website updates, website content is of course up to date, current on the latest in diagnosis and treatment information. And our website also houses a nationwide database of sites who offer free or low cost prostate cancer screening opportunities. And lastly, I wanted to highlight this upcoming educational events calendar. You'll see a variety of webinars hosted by both Zero and our partners at Us Too. I'd like to take another brief moment to thank Boston Scientific for their generous sponsorship of today's webinar. The Zero team is extremely grateful to you and for all of your work for the prostate cancer community, so thank you. Today's webinar will begin with a brief presentation led by Dr. Ackerman. Dr. Ackerman will present on radiation treatment and a new treatment advancement to reduce radiation risks called SpaceOAR hydrogel. After Dr. Ackerman's presentation, we'll then hear from Dr. Bullock, who will present on life after prostate cancer and side effect risk reduction. We'll take about 5 minutes after each presentation, so these questions can be directed to each speaker. And those questions can come at any time through the Q&A box in the chat. If you're listening through Facebook, we can also get your questions over to our speakers through Facebook. So put your questions in the comment boxes or in the Q&A box, and we will get those answered. We will do our best to get to each question. All right, let's get started. So first, it's my pleasure to introduce Dr. Scot Ackerman and Dr. Arnold Bullock. Dr. Ackerman is the medical director of Ackerman Cancer Center and a board-certified radiation oncologist. Ackerman Cancer Center has the world's only physician-owned proton beam. And prior to opening the center in 1997, Dr. Ackerman held the position of Chief of Radiation Oncology at St. Vincent's Medical Center. He has been in private practice for 30 years. Dr. Ackerman currently oversees the Ackerman Cancer Foundation and is a board member of We Care Jacksonville and was appointed to the Florida Board of Medicine. Dr. Ackerman serves as an integral part in Florida's fight against cancer.
Thank you. Thank you, Shelby.
Thank you, Dr. Ackerman. Next, we will have Dr. Bullock. Dr. Bullock is a professor of urology at Washington University School of Medicine. He is also a board-certified urologist and men's health expert. He specializes in the treatment of prostate cancer, bladder cancer, male infertility, male incontinence, and erectile dysfunction. He was recognized as a best doctor in America in St. Louis Magazine. So thank you, Dr. Ackerman. Thank you, Dr. Bullock, for joining us. Dr. Ackerman, I will now go off camera and give you the floor. Dr. Ackerman, it looks like
got it.
There you go.
Got it. Okay, good. Thank you. So I think I have the control. There we go. So good evening. My name is Scot Ackerman. I'm a radiation oncologist in Jacksonville, Florida. And tonight I'm going to speak about radiation treatment for prostate cancer, a little overview about some of the statistics or some of the way we diagnose prostate cancer. And then I'm going to close out my talk about this product called Spacer Hydrogel, which is a product that we use to allow us to treat the prostate safely while minimizing doses of radiation to the prostate and to the bladder and to the penile bulb and those areas to enhance quality of life in patients that are receiving radiation treatment for prostate cancer. So the agenda tonight, as I said, anatomy, statistics, diagnosis, talking about radiation treatment, and then the Spacer product. So here's the anatomy of the man's pelvis, and you can see that the prostate sits right between the bladder and the rectum, and so that's kind of an inconvenient spot for us to radiate, because when we radiate the prostate, we like to radiate an area just larger than the prostate to make sure we cover it properly. And those organs, the bladder and the rectum, are very, very close proximity to the prostate. Surgeons have similar problems when they go in to remove the prostate. They have to carefully go around the bladder and the rectum so as not to injure those organs. And so that's always our goal, is to treat the prostate and eradicate cancer in the prostate, while at the same time minimizing any injury to any organs near the prostate. So how do we diagnose prostate cancer? Most time these days is with the PSA test, the blood test, but also a digital rectal examination is still very important. And that's the way we can examine the prostate and feel the prostate and feel for a nodule on the prostate. Sometimes patients are detected because they go to the physician with symptoms of some sort, symptoms of pain in the pelvis or urinary obstruction. Those symptoms are typically frequency of urination or a slow stream. Even more advanced cancers can sometimes present with blood in the urine. But the only way to confirm the existence of prostate cancer and the severity of prostate cancer is by doing a prostate biopsy. So how do we do a prostate biopsy? There's two ways we can do it. We do it by putting a needle in the prostate. That's the common thing, but there's two approaches. One is by going through the rectal wall, as you see on the right, and on the left is a transperineal approach. So let's start with the picture on the left. So the picture on the left, we put an ultrasound probe into the rectum. Let me put my little laser here so I can show you. Where is it? There we go. We put the probe right here into the rectum, and that probe then shoots sound waves up toward the prostate. We could see the prostate with those sound waves, and then we place a needle through that template right here, through the perineum. And the perineum is the skin between the testicles and the anus. We go through that skin into the prostate, and by looking through that ultrasound probe, by looking on the screen, we can see exactly where that needle's going. And we can place it in a very discrete spot in the prostate and sample some tissue. The other way is by putting both the probe and the biopsy needle through the rectum. And this is the most common way. This is done frequently in the office, sometimes in the operating room. The probe goes into the rectum, we can see the prostate, and then right through the probe, we aim a needle into the prostate. So the differences between the two, the transrectal approach through the rectum is very simple and quick and easy. But the one thing that we're concerned about there frequently is infections in the prostate, because when the needle goes through the rectal wall into the prostate, it can introduce bacteria and can cause a prostate infection. With the transperineal approach, it takes a little bit longer to do, but it has a lower risk of infection. So grading. So when we take the tissue, we want to first of all see if it's cancerous or not. And if it is cancerous, we then want to place a score on it. And the score we frequently use is something called the Gleason Score. And no, this is not named for Jackie Gleason. This is a physician named Gleason who first proposes the grading system. And the system goes from 2, which is the slowest growing cancer, to 10, which is the fastest growing cancer. And the pathologist, she or he, looks under the microscope and looks how aggressive the cancer looks, how differentiated or undifferentiated it is, and then she or he applies that score to the tumor. We then look at the T stage, and the T stage is how we identify how much cancer is in the prostate. Smaller tumors are considered T1 and larger tumors become T2, T3, and T4. I'm not going to get into the intricacies of that because that's a whole lecture in itself, but the T stage goes from 1 being the smallest and 4 being the largest size tumor. And then the PSA blood test, that PSA score or that result, which should be below 4 for normal patients, as that gets higher, that makes us more concerned that the cancer might spread. So the Gleason score, the T stage, and the PSA together, we put them together to do this grading and staging, and we can identify patients that are considered low risk, intermediate risk, or patients that have high risk breast cancer. We also look at some other things, such as the PSA velocity. That's how fast the PSA has been going up. If a man has had serial PSAs over the months or years preceding, we do something called genomic testing, where we look at the prostate cancer cells and do a DNA analysis of them to see if the DNA changes within the prostate cancer is one that's aggressive or not. We look at the volume of the tumor, as seen maybe on MRI, to see how much tumor there is in the prostate. This will also help us identify a patient that's at more higher risk. And we have some other models and laboratory tests that we could do to see if a patient is at higher risk. And the 3 treatments that we think about and we look at in prostate cancer is surgery, removing the prostate, radiation, treating it with a radiation beam, or something called active surveillance, which is actually a treatment. It's not watchful waiting, it's active surveillance, where we're actively evaluating the prostate, we're checking the PSA frequently, we're maybe doing an MRI now and then, or even doing repeat biopsies to stay on top of the cancer. And all 3 of these have associated risks and side effects. And they all have different risks and side effects. The surgical risks are risks with surgery, radiation can be damage to other structures in the pelvis, and even active surveillance runs the risk of the cancer getting out of control and spreading to other parts of the body. And the risk with active surveillance is also anxiety about having this cancer in your body and worrying about it. So then here's the common treatment options within each of those. So within radiation, there's something called 3D conformal radiation, intensity modulated radiation, also called VMAT, stereotactic radiation, proton radiation, which is something I do a lot of. Within the surgical realm, there's the prostatectomy, the radical prostatectomy. There's one that could be done either open or laparoscopic, or even with a robotic treatment. And active surveillance, which is for patients typically who have slow-growing prostate cancers, and they may never need treatment for the prostate cancer. Instead, we recommend approaches to watch them very carefully, surveil them carefully, do biopsies periodically, and MRIs and those sort of things. And all of these have different risks and side effects, as I mentioned before, and typically regarding the bowels, the urine, and also sexual side effects. So let me focus on radiation because that's what I know best. And so prostate radiation uses radiation which is focused at the prostate to kill cancer cells. It also affects some of the surrounding tissues, and we're very frequently concerned there could be cancer in the surrounding tissues. So we want to treat some of the surrounding tissues, but the other organs in the pelvis, the rectum and the bladder and the penile bulb and the nerves that go through there are in very close proximity to the prostate, and they're very small spaces. And so radiation often unintentionally causes damages to those other structures. So what are the possible side effects of radiation? Are bowel dysfunction, meaning diarrhea, blood in the stool, rectal leakage. There could be urinary dysfunction as well, the need to urinate more frequently. And here radiation can be given from the outside, as you see on the left, those different modalities I mentioned before, external beam radiation or proton radiation, or also we could do radiation by putting radioactive seeds in the prostate, either ones that emanate the radiation slowly or ones that do it more rapidly. And so here's a picture of the problem with radiation. As you can see on the left, the radiation, that's a dose cloud. The red is the dose of radiation we want the prostate to get. And those other colors, as they get cooler, green to blue, those are lower doses of radiation that the structures near the prostate receive. And as you can see on the picture on the left, the rectum, which is just behind the prostate, receives a significant amount of radiation, and some of the red zone is in that. And on the right, as you see, which is a side view of the prostate, you see the rectum and the bladder get radiation, and the urethra, which goes through the prostate, we can't avoid. But the penile bulb, which is at the base of the penis at the bottom, you see that's avoided, and that's where a lot of the nerves go through for erectile function. And the anal sphincter is also avoided fairly well, and that is important to avoid because we don't want patients to be incontinent of their stool. And so with this, we've developed recently this product called SpaceOar. And SpaceOar, let me go back a slide for a second. We slide this SpaceOar product between the prostate and the rectum. And it's been shown, I'm going to show you more details about in a minute, it's been shown to decrease the risk of gastrointestinal side effects from 6% without it to 1%, and the risk of urinary issues from 32% down to 15%. So it's a marked reduction in side effects. We've always accepted 6% side effects of diarrhea and rectal bleeding as being okay, but going down to 1% is really a game changer. And with urinary side effects, we always expect patients, or frequently expect patients to have frequency of urination, maybe irritation or urination. To get that from 32% down to 15% is remarkable. And so the rectal radiation dose is usually unavoidable, but by placing the SpaceOar product, you can see it right here on my pointer, that little gel, we slide that in there, we inject it in there between the prostate and the rectum, and that moves the rectum and the prostate apart by about ½ an inch. And that ½ an inch in my radiation world is a mile. And so by moving it ½ an inch away, we can decrease the dose to the rectum by tenfold. So we're only getting 10% of the dose that we would normally get with conventional, without the SpaceOar rather. And also, when it's in there, it prevents the prostate from moving so much. So believe it or not, by putting that in there, we can be more precise with the radiation treatment. And in fact, it lowers the dose of radiation to the bladder as well. So the rectum is considered an organ at risk, OAR. That's why it's called SpaceOar. And so by putting it in there, we can reduce rectal toxicity, bleeding, frequency of stool. We also reduce the frequency of urination and pain in the rectum as well, which leads to increased quality of life. So what this SpaceOar does, as I mentioned before, we put it in there. It temporarily positions the prostate and rectum a little bit farther apart. We inject this gel in there. It's 2 tubes of fluid that go in to a needle, and as they mix in the needle, they become like a gummy bear. It's that kind of gummy stuff, and it stays in there for about 6 months, and then it's absorbed by the body. So it's just a synthetic, non-toxic polyethylene glycol, which is used in medicine all over the place. We use it in other areas. Plastic surgeons use it for filler. It's used in artificial tears. It's used in prescription drugs. To put this gel in, it's done briefly as an outpatient. I do it myself in the office. We put some little marker seeds in the prostate, and while we're in there, at the same time, we slide a small needle in between the prostate and the rectum, and we're able to inject the gel in that space there. And by having more space, we get fewer rectal complications, fewer urinary complications, fewer sexual complications, which translate to increased quality of life. So there's been SpaceOar has been published, over 75 peer-reviewed publications, 50,000 patients treated worldwide. It's reimbursed by Medicare and reimbursed by most private insurers. And that wasn't always the case. When it first came out, patients had to pay for it. Now it's reimbursed fine and by most payers. And so it's pretty easy to have access to. And so I try to stay on schedule. I got we're 20 minutes after the hour, so I think I did pretty good. I'll answer just a couple of questions.
Thanks, Dr. Ackerman. We do have a couple of questions coming in. And great job staying on time. I think I also went over, so well done. We have one question that came in from a patient, and he said that he understands how a SpaceOar gel protects the rectum from the radiation, but how does the gel actually protect against urinary side effects?
So the way it protects against urinary side effects, because it holds the prostate more still. So the prostate, when you're lying on the table for radiation treatment, and as you breathe, the prostate will move a little bit. It kind of goes up and down with your breathing, and the beam's on for a minute or two. So we compensate for that movement by treating a little bit larger area than we normally would. So the prostate kind of moves within that area. So now the gel's in there, and so we know the prostate doesn't move, and we can monitor that because the prostate stays more still. I don't know if that's the proper English, but because the prostate stays still, we have greater confidence in our aiming of the radiation beam. And because we have more confidence, we can tighten up the radiation beam more closely around the prostate, and hence there's less dose of radiation to the bladder.
Great, thank you. So we have a question here. Can you help this patient explain that, or excuse me, whether or not SpaceOar wouldn't be an option for a patient?
So there's a few instances where it's not. And the most common instance where it's not is if the prostate cancer is growing outside the prostate into the rectal wall. So we always get nervous when it's a large tumor growing through the prostate, through the capsule, and getting into that space between the rectum and the prostate. So frequently we see prostate cancer going through the capsule, but if it goes laterally through the capsule, that's not such an issue. But if it goes posteriorly through the capsule into the rectal wall, and then if we put the gel between the prostate and the rectum, we could potentially be moving some of the cancer cells away from the prostate and then missing those cells when we treat with the spacer. So that would be a contraindication. If a patient has had rectal surgery in the past, like maybe he's had a rectal cancer and has surgery, or anal cancer and has some surgery down there, that would be a relative contraindication. We could do it sometimes, but I can tell you that patients who have been treated with cryosurgery in the past that have failed that and need radiation, they're still fine candidates for the spacer product. We don't have an issue getting the gel in between the prostate and the rectum in those cases.
Wonderful. Now, is spacer a fairly standard practice in radiation therapy? And so, or do patients really need to advocate for the use of it?
Yeah, it's not as standard as I think it should be. Here in our community of Jacksonville, about half, maybe 40% of the radiation centers offer spacer. The way we did in the past was we would use a rectal balloon. So we would put a catheter in the rectum every day, and then the catheter had a balloon at the end which would blow up and that would dilate the rectum. So a lot of radiation oncologists still use a rectal balloon. The spacer, rectal balloon is easier because it's easier on the doctor. It's harder on the patient because putting the spacer in does take skill, and it's a technique that one needs to learn. And so a lot of practices, the doctors haven't learned that yet. I think they should. I think studies have shown that it's certainly much more safe than the rectal balloon. And so unfortunately, it's not. It's less than half the centers, I think, do it.
Okay. Wonderful, thank you. We'll just do one more question and then we'll have some additional questions for Dr. Ackerman at the end of Dr. Bullock's presentation. So last question for you, Dr. Ackerman. So if you have space, or does it reduce the importance of having an empty bowel during radiation?
What we do in our practice is we do the simulation for treatment. We do multiple simulations on a patient with and without his bowels full. And we see what kind of movement there is. The truth is, yes, it is less important. We still like our gentlemen to have a good bowel movement in the morning. Some patients, because they have a lot of constipation issues, even do an enema in the morning. But it's very unusual. It's only 1 or 2% of our patients. But it's always good to have an empty bowel and a full bladder for your radiation treatments.
Wonderful. Thank you so much for your presentation. Thanks for answering those questions. We'll pepper you with a few more questions at the very end. And for now, we'll hand it over to Dr. Bullock for his presentation.
Good evening. It's my honor and privilege to present to the community on life after prostate cancer. You know, our role as clinicians is not only to sustain life by definitive treatment of prostate cancer when indicated, it's also to help people recover from any potential side effects after they have radical prostatectomy or radiation therapy for our management of prostate cancer. There are definitive treatments that can be done. The most common complications after prostate treatment, be it radiation or surgery, would be 1, recurrence of the disease, 2, men having incontinence, either due to stress incontinence or urgent incontinence, and men losing their erections. So the long term, those are the 3 things that if we can prevent a person from having either of those problems, we've sort of hit the trifecta. So if you were to ask, what is your greatest concern after treatment of prostate cancer? Some men might say, well, I'd hate to lose my erections. But realistically, the biggest concern is, what happens if I leak urine? What happens if I'm incontinent after treatment? So there are definitive treatments, and it's all a matter of how dry you might choose to be. Well, the first thing is, we know that after prostate cancer treatment, you may leak. And it's important for us as clinicians to explain that you should expect to leak some urine for a few weeks to a few months after your prostate cancer treatment. Now, what I suggest to people that after a prostatectomy, by whatever technique, you are generally disturbing that internal muscle that sits between the bladder and the prostate, the internal sphincter. And we are dependent on that lower muscle listed here on your slide as sphincter, and that is the muscle we can control. In women, this muscle goes around the vagina and goes around the rectum. And in men, this muscle goes around the urethra and the rectum. So your biggest thing to retain continence is to do Kegel exercises to tighten that muscle. One study found that 1 in 10 men at 1 year after a prostatectomy continue to have stress urinary incontinence. Stress urinary incontinence is when you sneeze or you cough, or you stand up or bend over and pick up a box. You can leak some urine. And so that's stress urinary incontinence. And it's because that external sphincter muscle is weak. It's not strong enough to withstand the increased abdominal pressure that's generated when you cough or you sneeze. So initially after treatment, we suggest that people, even before they go in for their treatment, to purchase some absorbent pads. These pads are readily available at your local grocery store or pharmacy. And you can get pads. Pads are thin. The pull-up diapers are for more severe leakage. There are things called catheter collection devices. It's one that's sort of like a original coin purse, and you squeeze it and it pops open. And then when you let it go, it squeezes and it's absorbent tissue on the inside. There's a penile clamp. But to me, the most important thing before surgery and after surgery is to do pelvic floor exercises or Kegel exercises. After a woman delivers a child, they tell a woman to do Kegels by squeezing her vagina repeatedly to increase the tone. In men, our goal is to fatigue the muscle so that muscle, that sphincter muscle bulks up. So I tell men before surgery, three sessions a day, you squeeze your rectum closed and you try to hold it closed for 25 to 30 seconds. It's hard to do. You may only hold it for 15 seconds for the first couple of weeks. And you let it go, you rest for 30 seconds, you squeeze it again. So you do 5 squeezes, 3 sets a day. And if you start doing that before surgery, there's a good chance you'll be dry immediately after surgery. And you can continue that treatment for months until you are dry to your satisfaction. What happens if you are 6 to 12 months out from surgery and you're still leaking? And your leakage is such that, yeah, you don't have to wear diapers, but you have to wear, 3-4 thin panty liners a day. Then you have your option for a bulking agent like collagen, where you can inject it into the urethra. The best example of collagen is, what if someone wasn't happy with how thin their lips were and they wanted these nice, big, juicy lips? You can inject collagen or a bulking agent to bulk up your lips. It's a period of time where all the women on the cover of Cosmopolitan, regardless what their race was, had these nice, full lips. Well, that's a bulking agent. But you can use a bulking agent in the urethra, but it's not commonly done, I must admit. More of us use what's called a male urethral sling. A sling is placed by making an incision that's about 1 inch long right behind the scrotum. And you can dissect right behind the pelvic bone up to the obturator fossa, those 2 holes in the pelvis, and insert this sling device. And by inserting the sling device, it acts like a hammock, and it squeezes up on the urethra to compress it against the bone. And by using this compression in addition to the external sphincter that's just above it, thank you very much. By placing this sling device and compressing the urethra up against the pubis, you are adding another level of support for dryness. It is a simple procedure. It takes about 45 to 60 minutes to place it, and there are no catheters. So when a man wakes up, he is dry immediately. It is an amazingly good tool and is really underutilized. Now, what if a person has to wear 4 or 5 diapers a day? That's pretty severe incontinence. I must admit, we don't commonly get that degree of incontinence. But if a person wears 1 to 2 or 3 diapers a day, they need something more definitive. This is called the artificial urinary sphincter. It's been around for more than 35 years. The artificial urethral stricture is the definitive treatment. there is a cuff. There's a balloon cuff that sits around your urethra, and there is a pressurized reservoir that holds just under an ounce of saline. There's a cuff that's in your scrotum that is very small. It's yeah, and so you operate this pump, and by squeezing the pump 3 times, it releases the fluid around the cuff, opens up the urethra, and a man has 45 seconds or so to void. The pressurized cuff automatically refills. It is, again, why would you go around leaking when there are definitive things that can be done as an outpatient in order to fix this problem? I suggest that you visit this website, fixincontinence.com, where you can find more information. You can journal your pad use and answer some questions about your own incontinence and find more information, so that why live with a problem that you don't need to? Restoring sexual health. I do a lot of treatments for erectile dysfunction, both for men with diabetes, vascular disease, and post-prostatectomy. With the release of Viagra 22 years ago, there's very few men who have not heard about erectile dysfunction and know that this is a big deal here in the United States and around the world. But after prostatectomy, the nerves that supply your erections travel just in front of your rectum and just behind your prostate. And so if the dissection field is a little wide or a little deep, you could disturb the nerves supplying the penis. Sometimes it's a matter of redirecting the venous outflow from the penis with the prostatectomy that results in the erectile dysfunction. If it's a venous defect, that tends to resolve over time. But it could take as long as a year or 2 years to know if your erections are likely to come back. But even if they don't come back, there are all of these treatment options to help men who have erectile dysfunction. We all know about the oral medications. There are many of them. There's many medications out there, but it's important that a man takes them correctly. These medicines will not give an erection just automatically. They only work with stimulation. They work best if they're taken on an empty stomach. You have to give them time for them to be absorbed into your body, but they are very, very safe. There's 40, 50 million US men who've tried them, and it does not cause stroke or heart attack, but they cannot be used if a person is already taking a particular type of heart medicine called nitrates, generally used for men who have angina. Vacuum pumps. Vacuum pumps have been around since before I started residency in the mid-'80s. A vacuum pump is a device that slides over the penis. It uses a vacuum to create a suction. It sucks the penis up into the tube. You leave a ring at the base, and this ring is what you use in order to maintain your erection. It acts as a tourniquet. Now, there's some men who take an oral agent to achieve an erection, but the erection is not as rigid as they would desire. And so then they put a penile ring at the base to make the erection more rigid. So you can actually use the medication in conjunction with the ring. Penile injections are simple. It's hard to encourage men to consider it, but you're taking a diabetic-sized syringe and needle and injecting, 1/20th of a teaspoon of fluid into the corporal space. There are 2 corporal bodies that fill up with blood. 5, 10, 15 minutes after you inject yourself, the erection comes up. So the key to injection therapy is if you inject yourself, you're going to get an erection regardless of what else happens. So if you inject yourself, don't get into an argument about how the dishwasher has been loaded, because you're just walking around having a dishwasher argument with an erection. But it does work, and it's pretty inexpensive. And so injection therapy is something you should consider. And you can do this within months of the prostatectomy because you're not committing yourself to something that's a permanent solution. But now urethral suppositories called Muse came out before the oral agents. There are very, very few people who still continue to use these agents. Now, the most definitive treatment for a man who has problems with erections, I call it the Mercedes-Benz way of fixing it. Because when you get a penile implant, just like your Mercedes, that every day you go out there to start it up, it's going to work. A penile prosthesis is generally put in through a 1.5 incision, either at the base of the penis or at the top of the scrotum. You're trying to access the proximal portion or the portion of the prostate hitting behind your skin in order to slide 2 little inner tubes into the corporal bodies. It's sort of like putting an inner tube in a tire. And once that inner tube is in the tire, no one can tell which tire has the inner tube. So when an implant is properly placed, I tell men, you could look at your own self in the mirror at 2 months and you shouldn't be able to see it. But whenever you want to have intercourse, you operate this pump. And when you operate the pump, it transfers fluid from a reservoir that's hitting underneath your muscle into the cylinders, and the erection occurs. When you're done, regardless if you're done in 3 minutes, 10 minutes, or 50 minutes, you hit a release button and the implant deflates. Very reliable tool, been around since the early 1970s, and is covered by your insurance companies. So most people don't realize that implants are actually covered through your insurer. It's very few insurance companies don't cover it. What are the risks? And again, the biggest risk is the risk of an infection, putting a foreign body in, just like a risk of putting in a knee. But that risk is fairly small in people who do a lot of implants. And so I know at Washington University in St. Louis, where I work, my infection rate is just over 1%. 1 in 100 will get it. I tell people it's a 1 hour surgery, 1.5 inch incision, 1 night hospital stay, and 1 week of real discomfort where you probably change out your schedule. So how do you track your progress? Well, I think that when men are 6 months out and they have no reaction to any stimulation, odds of your erections coming back are pretty slim. And there's no reason to go a year, 2 years, 4 years without seeking definitive treatment. But I direct you to edcure.org in order to get more information and to get an assessment of what might be your erectile function. So some of the questions: how long does it take to achieve bladder control? Most people are using 2 or 3 pads for the first month or 2. I hope that when the majority of my patients are 4 months at most, are using 1 protective pad. I think that there's a percentage of people, 10%, who are 4 or 6 months who are still using a pull-up of some sort. And it's those men that we hope through continued Kegel exercises that they can strengthen that muscle and have a lower chance of needing to get a surgery, at the 12-month period. Why don't all men recover erectile function? Well, the number one reason is men don't tell the truth about how bad their erections were before surgery. So we know that 50% of all men over the age, between ages of 40 and 70, have some degree of erectile dysfunction. So it's important for those men who question how good their erections are to try the oral medications before surgery and use that as comparison for how likely their erections will be after surgery. But if they don't come back, we can oftentimes make a man's erections better than what they were before. Are penile implants covered by insurance? They sure are. But I direct people not to call the insurer yourself. There are insurance specialist nurses who work in our offices who do a lot of implants, who know exactly the phraseology in order to get these things covered. I think when you talk to men who've undergone a male sling or men who've had penile implant placed, one of the things that they say over and over again was, "Doc, why didn't somebody tell me about this earlier? Why did I go 5 years before I found out about this by accident? Man, I should have done this 6 years ago." And so the highest satisfaction rate of all the treatment options for erectile dysfunction is a penile implant. But again, do your research. There are people who put in 5 or 6 implants a year, and there are people who put in 50, 60, 100 implants a year. I don't think you necessarily have to have somebody who does 100, but someone who does a couple dozen at least. I mean, who would you take your transmission car, a high-end car? Would you take it to somebody who does a transmission every week or one every, couple months? So there are ample resources. The 2 I've listed: the American Cancer Society, the Prostate Health Education Network, FIN, which is an amazing organization, US2, International Prostate, and Zero. I mean, there's a host. All of these are legitimate organizations that the information that you find at these sites is legit. You can take it as, as word and as truth because they're being peer reviewed by so many people. So there are many treatments for every man who has prostate cancer. There's erectile restoration is very common, 30, 40% at least. Urinary control. And if you're leaking all over the place, you probably want to get your leakage fixed before but why not do them both at the same time? You absolutely can do them both at the same time. The man who comes in with a partner is clearly the man who's going to have the best outcome. It just seems to be that way. So look, I appreciate your time. I appreciate your attention, and I hope I've shared some helpful information. So.
Thank you so much, Dr. Bullock. We have a lot of questions coming in, and you guys both did a wonderful job buzzing through those slides, and I think leaving a lot of time for these wonderful questions coming in. So again, we'll try to get to as many of them as we can, and we'll focus a few first on your presentation, Dr. Bullock, and then Dr. Ackerman. There are several for you as well. So I think the first question for you, Dr. Bullock, is a little bit more about the sling. I think you've mentioned how many patients have expressed their happiness with it, but does the sling tend to weaken over years?
No, what we found is that the sling really is a permanent solution. The most important thing for the urologist and the patient are to be clear on how severe the leakage is. A person who's using many diapers a day, the sling is probably not your most effective treatment. There's no doubt that the sphincter, the artificial sphincter, is more a more definitive treatment. But that means every time you want to urinate, you have to operate that pump. A person who's using 5 diapers a day, that's great. That's a wonderful option. But the person who's just using a few pads a day, not having to do anything, just go to the boys' room and urinate. That's the beauty of a sling, if you're an appropriate candidate.
Wonderful, thank you. We have another question. Can you have both a urinary sphincter and a penile implant?
Absolutely. I do that all the time. So a person who, now, mind you, this is the way I do it. Different urologists do it a different way. I always put the sling in first. I have the sling done. The person is in the lithotomy position, like the birthing position in the operating room. Me personally, I've just dealt with a urinary field, and we've looked in the bladder. After my sling is placed, I take all the dressing down. And we start from scratch. All the dressing comes down. We reposition the patient back flat on the table, and we completely re-prep with ChloraPrep and re-drape and put the implant in through a different access, because one's behind the scrotum and one is above the penis, because I don't want those two operations to ever meet. So yes, absolutely. We're doing them up on the same anesthetic.
Wonderful, thank you. We have a couple of questions actually rolling in around the Kegel exercises. The first question is regarding a patient who's really just having trouble learning to do them on his own.
Right.
And what you might recommend. He's wondering if you might recommend seeing a pelvic floor physical therapist or a general physical therapist, or if there are specialists.
No, you're right. There are specialists. There's some urology groups that hire a physical therapist, and they teach this with biofeedback training. And so, but generally speaking, most people get it. And the person who really doesn't get it, I just try to make it real. I say, imagine you're on an elevator with crowded elevator with all supermodels, and you're the only man on there. You need to pass gas. Whatever you do, not to pass gas, that's a Kegel. So that's a Kegel. Just squeeze your rectum. Like, I know you got to pass gas. You're on the 5th floor. Hold it from the 5th floor down to the 1st floor until all the ladies hop out, and then you can let it go. That's a Kegel. So most people get it. Like, whatever you do, not to pass gas. It's not a butt cheek exercise. It's more an internal anal squeeze exercise.
Mm-hmm. Right. And to your knowledge, is there any published data that that points to pre-treatment of Kegel protocol that significantly reduces urinary incontinence?
I can't recall a study of such.
Okay.
But there's no doubt that you can strengthen a muscle in your body, be it your biceps, your leg muscles, or your pelvic floor muscles. And the key to bulking up a muscle, if you have somebody like Schwarzenegger, is you have to fatigue the muscle. You have to put stress on the muscle. You can't, be a 200-pound guy curling 5 pounds and think your biceps are going to get bulky. You have to put an amount of weight on them that makes your muscle have to do more work. And the response is the muscles get thicker and thicker and stronger resting pressure.
Absolutely. Thank you. All right, Dr. Ackerman, I'm going to start hitting you with some of these questions as well. They continue to roll in. So thank you to our participants for being so engaged. The next question that came in is, I'm sorry, I just lost it. They're coming in so quickly. I think this one might be back to Dr. Bullock. How long is too long to wait on penile injections? And I think this also speaks to just bringing up your side effects to your treatment team.
Well, there's no reason that you can't start on penile injections immediately. So if you've tried the medicine, let's suppose pre-op, and the medication wasn't working, once you're out from your 5-week, post-surgical recovery, or once you're out from your radiation therapy. But again, the erections with radiation therapy, the loss of erections doesn't happen immediately after radiation therapy, generally speaking, as it does after surgery. And Dr. Ackerman can correct me. But there's no reason to wait on injection therapy because there's no long-term harm to doing that. So you could do it at 5 weeks.
Great, thank you. While in process with hormone blocking therapy, is there likely to be any immediate benefit from taking erectile dysfunction medication?
Absolutely. So, you look at people back in the day, you go back centuries ago, and you think that these eunuchs weren't having intercourse. But of course, we know one emperor can't handle 400 young women, right? And so we know that men back in the day, when I was a resident, before we had Lupron, people would undergo simple orchiectomy, right? We take the testicles out. And so we know that you can still get an erection with no testicles, no testosterone. Now, you may not think about it. Your wife might have to say, hey, honey, why don't you come upstairs with me? I want to show you something. I want to let you see something. And, the wife might have to be more engaging in that. But your testosterone is not essential for you to get a hard penis. No.
Right. Dr. Ackerman, I think this one's really directed to you. How does salvage radiation affect the chance of erectile dysfunction?
Well, generally, patients that have had a prostatectomy already have a compromised erectile dysfunction. And the truth is that it's difficult with radiation after prostatectomy to avoid some of those nerves. We still do our best to avoid those nerves, but still radiation just adds insult to injury in those patients. And so, yes, it does affect erectile dysfunction.
Okay. And this is a kind of a longer question, so bear with me, but I think this is going to be a really insightful answer. So after a radical prostatectomy a couple of years ago, followed by radiation, the continence seems to be good, but not perfect. But now a couple of years later, there seems to be in this patient some pain in the bladder that is relieved in the morning after urination, but it seems to be pretty common for this patient, and he's wondering if this could be something serious to bring up with his treatment team.
So in addition to treating prostate cancer and erectile dysfunction, I do a lot of men's voiding dysfunction. You see these commercials on TV where women are running to the bathroom. I love the one on the airplane with his little bladders yanking this woman to the bathroom, right? And I always ask men, I said, so, if your lady had to go to the bathroom very often and she had discomfort forcing her to race to the bathroom, would you ever treat her prostate? Right? And that's what are you talking about? How are you going to treat her prostate? So as we get older, men and women have what's called an overactive bladder. And that means that you have a bladder spasm that forces you to go to the bathroom. You could consider it a cramp, right? It's a spasm. And so some people, when they get this urge to go, they have to go right away. And some people feel this urgency to go. Some people feel a discomfort with that message to go. And as soon as you go, the discomfort's over. That sounds like a bladder spasm. You could do a urodynamic study in the urologist's office. It could be a definitive diagnostic test, routine procedure. Or some people say, how about we prove that you're emptying your bladder and give you a trial of a bladder relaxing medicine and see if it works. If it works, doctor, you're a genius. That's what happens. Doctor, I've been suffering with this. You're a genius. And so it's a simple thing. I think you got to look at bladder dysfunction because men have bladders too.
Right. We have a question from a patient who has Peyronie's disease and wonders if using an implant would be a problem or will it solve the curve problem?
So it depends on the degree of Peyronie's disease. So oftentimes, like in our practice, we had this big national teleconference to up and coming implanters on how we fix Peyronie's disease in conjunction with an implant. So most people with a mild curvature, 10, 20 degrees, you put in the implant, you do a little modeling of the penis under surgery, and it's fairly straight. But when you're talking, 35, 40, 80 degree of curvature, usually you go and see a Peyronie's disease specialist, not your average Joe urologist, not even your average implanter like myself. There are male reconstruction specialists who are experts at doing this. And there's not that many of them around the country, but there are people in all parts of the country that you should go to. But again, this is not going to your average Joe urologist. This is, you have that degree of curvature, do a little research. You'll find a Peyronie's disease surgical specialist who will put in your implant and straighten your penis under the same anesthetic.
Great, thank you. What are your thoughts on, Dr. Bullock, this one's for you. What are your thoughts on the efficacy and usefulness of ultrasound therapy for ED?
Well, you're really talking shockwave therapy for ED. And I think that this works for those people who have mild ED and they're taking medication with some degree of effectiveness. And the shockwave therapy probably will take them to a point where they're more pleased with their erections, either with or without the medications. But men who have had years of severe ED where they can't get any erection, the medication doesn't work at all. I really wonder into, folks who suggest that people pay a few $1,000s cash money for that treatment, when for typically $300 or $400 or less out of pocket with insurance coverage, you'll get a 10, 12, 14-year penile implant that works anytime you want it to work, for as long as you want it to work, with the normal sensation to you and your wife. And as some men say, you get your man back. You know what I mean? It works so reliable, you can talk crap, And so it's a more definitive way to go with less money out of your pocket.
Thank you. We have another question. Wondering if, I think either one of you can talk about the other common side effects of surgery, including leakage of urine during sexual activity.
Let a radiation doctor talk about surgery complications. It's gonna make it sound terrible.
No, go ahead.
Well, absolutely.
I think that's the risk. I mean, you have the risk of surgery that you have with every surgery. And to be honest with you, your sicker patients, or some patients say, doc, the risk of cardiovascular events, right? If I have a person who's on heparin and on a blood thinner, or had a heart valve, and he has to be on high dose blood thinners, maybe that's not the best guy for surgery. And so we refer patients to radiation oncology who are your 50-year-old men who honestly, radiation's a better option. And quite honestly, sometimes our radiation oncology people refer us to someone who is a younger guy with, disease that they may feel that it would be appropriate for them to also consult with a urologist. And let me just say, this is one point I had. Finally, after my kids finished college, I bought a high-end car. I wrecked this car. They make me take this car to 4 shops before they total this car. How many people see a surgeon and see one surgeon, even if they're getting their liver taken out? How many people know that there's a surgeon for prostate cancer, but don't take the time to at least go see a radiation oncologist? Most people take their car to more shops and get more opinions on their Buick than they do when they have a major medical problem. It makes no sense not to get second opinions.
It's so true. So true.
Yeah, absolutely. Thank you. We have another question. Do you recommend a penile rehab regimen for men who have had radiation?
No, we don't really have a regimen. Our patients typically have very little diminishment of erectile function after radiation. Most of our men, if they have some, that are older and they're getting older, and so they have some erectile dysfunction, and most of them will respond well with some of the oral medications.
Thank you. We have a question about a product, wondering if you've used InterStim 2 for overactive bladder problems after radiation?
Dr. Bullock.
So InterStim is a medicine that usually the urogynecologist or the urologist put in. Again, this is a specialty area of urology. Urology is already a specialty area, but this is a real specialty, subspecialty area. I've never put in an interstem. There are bladder dysfunction specialists who basically read these urodynamic studies. When we are puzzled as to what's going on with the urinary system, you can slide a catheter into the bladder, it's hooked up to a computer, slowly fills up your bladder, and it shows, instead of your bladder pressure staying flat until it gets nearly full, the bladder just starts spiking, even at 3-5 ounces. When these people don't respond to medicines that are the antimuscarinics, like these commercials I mentioned on TV, there's a lot of commercials, right? There's the pastel colored balloons, there's a women stick people dancing, there's a woman missing her daughter trying on the wedding dress. Those are all the bladder medicine. When they fail these medicines, then a bladder specialist, the female urology specialist, as we call it, is probably not gender correct, can put in this thing called an interstem. It's like a pacemaker for the bladder, and it's amazingly effective. Again, people have these problems, and they just are so shy about mentioning what their problem is that they miss out on these amazingly effective treatments that have been around for years.
Thank you. Dr. Ackerman, we have a question for you from a patient who has had a hip replacement and wondered what, if any special precautions are required for radiation and proton treatment.
Yeah, so the issue with hip replacement is mainly regarding proton beam radiation. With conventional IMRT radiation, we are able to safely avoid that. So the hip is metallic and it's very dense, and so radiation goes through it because the radiation vaults are pretty thick. We have 6-foot thick concrete walls, so certainly we can get through a hip replacement. But when the radiation beam goes through the hip replacement, there's some electrons that are produced by going through that, and it could deteriorate that hip replacement. It could affect the bone that the hip that the artificial hip is cemented into. So classically with proton beam radiation, we shoot the beam in from the right and the left, and it goes through the hips. So patients with hip replacements are, in many instances, are excluded. We have found a way around that. And what we do is we aim the beam on one side where the hip is up a little higher, and we're able to avoid the hip completely. We come in at an oblique angle to the prostate with one beam, and the other beam comes in from the side. We even treat patients in my office with 2 hip replacements by having both beams come in on angles from above. And so we just shoot the beam in such a way that we avoid that hip replacement.
Wonderful. We have another question, Dr. Bullock. Is there an option for when after or if the artificial urinary sphincter starts to deteriorate or wear out?
Yeah, so that's one of the, again, a person who needs an artificial urinary sphincter, you're using 4 diapers a day. That means you are very limited in what you can do. You're not going to hang out at the symphony, let's say. So an artificial sphincter is an amazing tool, even though it has some drawbacks. So imagine having a cuff around your finger tight all day, every day for 5 years. And you take that ring off, we see people at the time of surgery who've never taken off their wedding ring, and you see that tissue where that ring is a little atrophic. That tissue is not as thick as every other piece of tissue around it. So after 10 years or so, that cuff could wear down on that side of the urethra. It's simple. All they do is take that cuff out and put it on another position on the urethra. So every 8, 10, 11 years, sometimes they do it proactively before it wears down, and they just take you back to surgery. They reposition the cuff and you're back in order. What if the cuff is not working? What if one cuff is just not doing the job? Urethra is thin. They can do a double cuff. They can put cuff, use a Y connector. It's sort of like, 2 cuffs instead of 1. So yeah, these reconstruction experts who do a lot of sphincters, they're pretty good at it, and the results are good. Again, it's a matter of experience. When to make the cuff the right tightness. You want it to be on there, but you don't want it too tight, but it can't be too loose. It's got to be just right. So.
Thank you. And last question, unfortunately, we're not able to get to all of them, but I thank you both so much for your thoughtful answers. But we'll squeeze this last one in, and then we'll wrap everything up. Can you get both a sling and a penile implant at the same time? And can you still do that if you have had radiation therapy?
Yes. So again, people who had radiation therapy, we worried that they could have some degree of bladder spasticity. Before we put in any type of restrictive device, a cuff or a sling, you want to make sure that they don't have high pressure spastic bladder, because you want that pressure to be able to pop off. And so, but it's just a routine part of the evaluation. The radiation therapy, as Dr. Ackerman, the pictures were amazing. His presentation was wonderful because it shows how accurate they can be at treating the areas above the external sphincter in the pelvis. And so that's the reason why when we're treating the urethra below the external sphincter, technically that area has had minimal radiation gain.
Right. We avoid that area.
The pictures were great. It was a wonderful presentation showing you how accurate that can be.
Thank you, Dr. Bullock. Yours was too, sir.
Thank you.
Yeah. Well, thank you both. I'll echo those sentiments. Wonderful presentation. Thank you so much for taking so many questions from our very engaged audience, almost 200 active participants with us from all over the United States. So again, just a huge thank you to both Dr. Ackerman, Dr. Bullock, and to our generous sponsor, Boston Scientific, for such a wonderful webinar. So thank you both for dedicating a late evening with the Zero team and with the prostate cancer community.
Well, thank you to the Zero team for putting on such a well-run program, and to Boston Scientific. I appreciate the opportunity, and I'm sure we've gotten some good information out to the participants.
Yeah, Space Sword and Zero Cancer, you guys are doing phenomenal job. Thank you.
Thank you so much. We really appreciate that. So to our attendees, I just want to make one last plug. Please take a moment to fill out the survey so we can continue to bring you all of the information you both want and need while you fight prostate cancer or your loved one fights prostate cancer. Visit our website, zerocancer.org/webinars for this recording, or zerocancer.org to learn more or to get involved in the fight against prostate cancer. This is the conclusion of tonight's webinar, and one more thank you for joining us, and good night.
Good night.